Hi everyone, my name is Meredith Freeman. I'm a fourth-year medical student from Tulane University in New Orleans, and thank you so much for having me. It's a real honor to be here, especially my native habitat is 2 feet below sea level, so it's pretty cool to be in Denver. So I'm going to present our manuscript, The Battle of the Buttress, hopefully the paper to end all papers in regards to safe-line reinforcement and sleeve gastrectomy. So here are our disclosures. So vertical sleeve gastrectomy has been demonstrated to be safe and effective. However, there is still controversy regarding how to reduce major complications, particularly bleeding and staple line leaks, especially considering this is an elective procedure. So our goal is to evaluate the effect of 3 techniques: no reinforcement, oversewing of the staple line, and using buttress reinforcement on several clinical outcomes, but especially bleeding and staple line leaks. And because these complications are so infrequent, we needed a very large sample size, so we used the largest database we have, the MBSA QUIP. So we start out with almost 1 million patients in the database from 2015 to 2019, and after excluding our exclusion criteria, we were left with over 500,000 sleeve gastrectomy cases, and from there we separate them into no reinforcement, oversewing, buttress reinforcement, and this combination group of buttress and oversewing. Okay, and with those that met exclusion criteria, we performed a temporal analysis, both of complications and reinforcement technique trends over the time period. And then we performed 3 propensity-matched analyses between the 3 methods, as seen here, for over 30 major and minor complications. And lastly, we performed an analysis comparing patients who experienced bleeding to those who did not. And here are our baseline characteristics. It's nothing surprising. It's very representative of the overall bariatric population. I wanted to point out that 75% did receive some sort of reinforcement, and 88% of these cases were conventional laparoscopic procedures. Okay, and then when looking at our trends over time, we see that buttress reinforcement is the most common reinforcement technique. You can see that no reinforcement increased over this time period. The combination approach decreased. The others did not change to a degree of statistical significance. And then over the same time period, leaks experienced a decrease. Bleeding also saw this small decrease in 2016, but did not demonstrate a significant decrease overall. So our first propensity match comparison was between buttress reinforcement and no reinforcement. The green section here indicates factors in which buttress reinforcement demonstrated a clinical benefit. So I want to point out major bleeding, overall bleeding, and reoperation. However, no benefit was seen in regards to leak. And buttress reinforcement was associated with longer operative length and length of stay. And our second propensity match was done comparing oversewing versus no reinforcement. As you can see, oversewing was only advantageous in regards to overall bleeding. Oversewing did have a slightly lower risk of bleeding, major bleeding, reoperation, and reintervention, but this did not reach statistical significance. And like buttress reinforcement, oversewing was associated with the longer length of stay and operative length. Then when directly comparing buttress reinforcement and oversewing, buttress reinforcement demonstrated shorter operative time and shorter length of stay, and also fewer pneumonia and DVT events. And otherwise, all major outcomes were comparable between the 2, including leak. And you'll notice there's no red section here, and that's because there was no advantage to oversewing in this analysis. And so lastly, because bleeding was our most common complication and because in our temporal analysis it didn't see the same downward trend that leak did, we compared patients who experienced a bleeding event to patients who did not. So again, it was our most common complication at almost 0.7%. The bleeding cohort was more male and experienced more DVT, or had more of a history of DVTs, smoking, chronic kidney disease, COPD, chronic steroid use, and sleep apnea. And every major complication was notably higher in the bleeding group: operative length, length of stay. Also the unplanned ICU admission, that was a 600 times increase. Reoperation also was a 600 times increase. And then of course, readmission, reintervention, mortality, and leak. And I want to point out here that patients who experienced a bleeding event were more likely to have had no reinforcement and were less likely to have received buttress reinforcement. And furthermore, when we look at the management of these bleeding events, we see that bleeding is more than just bleeding. In the majority of these cases where a bleed occurred, non-operative therapy was the most common treatment, whether it was transfusion, observation, or endoscopic management. But reoperation was the second most frequent treatment. So no matter which reinforcement technique was used, more than a third of these patients required a second operation. And again, I would like to point out that bleeding was highest in the no reinforcement group, followed by oversewing and buttressing. So in this analysis of over 500,000 patients undergoing sleeve gastrectomy from 2015 to 2019, we saw that postoperative bleeding was the most common 30-day complication, and that patients that experienced bleeding had longer duration of surgery, longer hospital stay, increased reoperations, readmissions, reinterventions, and increased mortality. Blood transfusion was the most common treatment option for these bleeds, followed by reoperation. And the use of no reinforcement continues to increase, even though the rate of clinically significant bleeding was higher in the no reinforcement group. Unfortunately, no method demonstrated a positive effect on leaks, but overall patients with any level of bleeding were more likely to experience leaks. And therefore, we conclude that the liberal use of buttress reinforcement is recommended for further optimization of patient outcomes after sleeve gastrectomy. Thank you.